Okay, looks like I have just a couple of students who are finishing up. Who is still working on this? Make sure you've submitted. Okay. Okay, good. It looks like everybody has submitted. How'd you do? Did you read through your week 4 or 5 notes?
Yeah.
Was that information in there
Yeah.
for your quiz? Okay. If everybody could come back on camera. Jordan, Charmaine, I can't see you. Hey, let me share my screen and we'll go through it. Okay. I've got 2. Okay. All right. Okay. All right. Can everybody see my screen?
Yeah.
Okay. Okay. Let's go through number 1. The nurse is assessing a client with PTSD. What would be an expected finding?
A feeling of intense distress along with anxiety, nightmares, and flashbacks.
Okay, does everybody understand why that's PTSD?
Yeah.
Okay. Okay, number 2, which statement can be applied to blood alcohol concentration?
It's 3. The liver can metabolize 0.2 ounces of liquor, whiskey
Mhm.
per hour.
Okay. Anybody have any questions about that one? And then just for the record, how do you measure, is blood alcohol concentration measured by just how much you consume? What other factors are taken into account when measuring the blood alcohol concentration?
Your weight.
The
Weight?
rate, whether it's female or male,
Mhm.
um,
Amount
The amount.
consumed?
How
the
much
amount,
they drunk?
What?
I was saying the same thing you said. How much they
the
drunk?
concentration.
Mm-hmm. When's the last time they ate?
Mm-hmm.
Right? My point is, it's not only the amount consumed that measures your blood alcohol concentration, and that's in your notes. There's other contributing factors.
You know.
Okay, number 3, the LPN prepares to care for a client with anxiety. What might the nurse observe? Select all that apply. What do we think? Is A correct answer?
Is the first one
In the last.
and the last one.
Yep.
Okay.
Dang, I want to move.
Okay, A and D are the correct answers. And again, that was in the anxiety section of your mental health, well, the mental health concept. The top one was anxiety, and we'll go through that in the notes.
Temperature hot.
Which of the following, while the nurse is working with
B.
pregnant teens, the focus for the long term, which of the following? What's the most important thing we need to do with
B.
pregnant teens long term?
Keeping them in
Make sure
school,
they have education.
Keeping them in school,
Mm.
right? Completing their education. Why is that a priority? What benefit does that have?
They
If
can
they, oh, go ahead.
go ahead.
I'm eating. Go ahead, babe.
It helps with the poverty rate.
Go ahead. I'm listening. What
The
is the
more,
benefit?
the more you're educated, the better decisions you'll
bet-
make. I mean, you'll be more
Exactly.
resilient in certain
Exactly. The better decisions you're going to make for both yourself and your family, right? Excellent. Number 5, culturally competent nurse is leading an in-service for nurses on the care of patients who are LGBTQIA. Which statement by the nurse conveys the most accurate information about the acronym?
C. Oh, it is a term that reflects both. Hey,
It's C.
See, it's a term that reflects both gender identity and sexual orientation identities. Anybody have any questions about that question? Okay, question 6. Which of the following should be the initial consideration made by the nurse who is working with LGBT families, homeless, and pregnant teens?
B.
We talked about this the week before last in week 3 classes, right? Working with these vulnerable populations, right? You have to have an understanding, right, of your own personal feelings, values, beliefs, and working with anyone that you provide care to. And that's really with any vulnerable population, right? You have to understand your own, come to terms with your own personal biases, prejudices, feelings, values. Okay. Number 7. Which intervention isn't, hope everybody caught that word, isn't appropriate for caring for clients undergoing alcohol withdrawal?
Maintain an NPO status. You want them to be hydrated.
Right. We're going to be doing everything else, monitoring vital signs, providing a safe environment, addressing hallucinations if they're having them therapeutically. But we do not want to maintain an NPO. We want to push fluids, right?
Mm-hmm.
Okay. Nurse is assessing a client with a binge eating disorder. The nurse understands which other comorbidities are commonly found with this disorder.
It's
Family history
family
and
history and
depression.
depression.
Pardon me?
Family history and depression.
Yep. Family history and depression.
So why is it a binge eating disorder? Like it runs in a family that you
I
binge
ain't even
eat?
see binge eating on here. Where y'all saw?
It's not. So that's what I'm trying to figure out because I put depression and like the fear of loss. Like I know, I was watching a TV show and this lady just kept on eating ice cream and kept on eating ice cream, and she had a fear of loss, which was her husband ended up leaving her. So where you getting that family history from?
Family with mental disorders, and this is considered, this is in the family of mental health issues.
Binge eating?
It's in the family of mental health issues, binge eating.
Oh yeah,
family
you know,
history.
like when somebody is sad, they be like, I'm just gonna go over here, and they just go and eat until they feel better.
Yes.
That's like
they say
that's mental. They say that's in the mental health field too. That's like the form of depression as well. So,
okay.
but they call it stress eating. Then some people do stress eating,
and there is a known family history.
and some people don't want to eat when they upset or depressed.
Excuse me. Yep, that's exactly right. Which of the following are signs and symptoms of alcohol abuse intoxication? Which would the nurse likely expect to see? Select all that apply.
Is it drowsiness and slurred speech?
Right. Because somebody who is intoxicated is not going to have steady gait, and they're probably not going to be alert.
Nope.
Right?
Right. They're going to be moving all over.
Yep. And the last one, the nurse is caring for a client with a terminal disorder is close to death. And reviewing the plan of care, the nurse determines which action is a priority. So you're looking for what is the most important?
Maintaining the client's dignity and then make sure that they are free of pain.
or as pain-free as possible,
Right, of course. Because dying is painful, they say. So
right?
it's yep.
And none of the other ones even make sense. Or the other ones are incorrect, actually. All right, so maintaining the client's dignity to ensure as pain-free as possible. Okay, so how'd you do?
I got that family history one wrong with the binge. That was it. Other than that, it was good. Everything was in our notes. I just picked depression and the fear of loss with the binge eating, and it should have been the top one and the second one. But
Right.
overall, I did good.
I did
Okay.
too.
All right. Okay.
Oh, which one? I didn't get it wrong, but I was going back and forth on that question about the LGBT community, where
Mhm.
it said no. I had read in the review that you had put out that it said the first one, it was like knowing the rights of like marital status and stuff. So I was going back and forth, but I just chose the other one because I knew that one was definitely correct.
Yeah, but you had to read. You had to read it again. I had to
Yeah.
read. I had to read it again to get. They wanted to know what the acronym mean. So
Mhm.
like with everybody,
No,
what I'm
not
saying?
that,
Like
not that one.
oh, which you talking about that one? Oh,
Okay.
Yeah,
So
this one
okay,
that she
so Latour, so you are correct. If the question didn't say what should be the initial,
yeah,
okay,
okay.
that's actually correct, right? C is correct.
Mhm.
So, but it's asking what is the first thing we need to do? The other
Mhm.
answers are
Uh,
so that's
really-
a good question of if more than one answer looks correct, you got to go back and read the question, right?
Mhm.
And see if you missed a word. And the important word here is initial, right?
Okay.
Because initially we have to make sure we check our own feelings, right?
Mhm.
Down the road, once we have done that, we can be learning about the marriage laws within the state. We can be doing assessments about the family and work structure, right? So, but the question was asking initial. Very first thing is we need to check our feelings. Does that make sense, Latoria?
Yeah.
Okay. Okay. All right. Let's talk about our content from. So basically, we're going to go through a review since hang on. Who's trying to get in? Jatarius. Okay. So we talked about pregnant adolescents, LGBTQ, mental illness, alcohol, tobacco, and other drug related problems. Let's just go through our notes and see what we didn't cover. Okay, well, we didn't cover a lot in the quizzes, but I tried to make the quizzes a variety of questions for a variety of topics. What do we know about special vulnerable populations? Okay, we know they often have poor health outcomes compared to other people, right? They have high prevalences of chronic illnesses. This is special vulnerable populations in general. High prevalence of chronic illnesses, hypertension, high levels of communicable diseases, maybe TB, hepatitis, STDs, upper respiratory issues, higher influence or higher incidence. We know that they have higher morbidity and mortality rates, right? Because why? Maybe poor living conditions, living in poverty, maybe don't have access to nutritional foods, don't have good access to healthcare. Maybe they live in communities that have a high rate of crime and violence, including domestic violence. So overall, vulnerable populations are much more at risk for poorer outcomes, right? One of our our first special vulnerable populations is the pregnant adolescents. We know that there's a direct correlation for pregnant adolescents between poverty and poor health outcomes. That's a fact. Okay. We know that they're 3 times more likely, or excuse me, 3 times more likely to drop out of school. Right. So that was the question in your quiz about keeping them in school. Right. When education is completed, when educational programs are completed, chances are increased for a better future. Right. Which may improve health care over the long term or over the lifespan. Okay. Pregnant homeless women now present several challenges. Higher rates of STDs, higher incidence of abuse of alcohol and drugs, poor nutritional status, and certainly the higher incidences of complications at birth or poor birth outcomes. Okay. We know that racial and ethnic minority groups have our higher rates of teen pregnancy. Okay, maybe due to poverty, educational opportunities, higher rates of abuse, violence, sexual victimization. Right? Factors that contribute to teen pregnancy. We talked about that: low income, lack of education, lack of support, lack of social support networks, maybe living environment risks. We also know that adolescent pregnant teens experience higher rates of domestic violence. So if you're working with a pregnant teen that is involved in a domestic violence situation, you should be working with them to develop a safety plan. Okay? And this paragraph talks about safety plan. What should it include? We have to have a safety plan working with this group prior to their discharge. Right? Whether they're suffering domestic violence or intimate partner violence. Right? Including a bag, concealed bag with clothes, documents, money, credit card that cannot be traced, spare car keys, phone numbers for nearby shelters and services. Okay, and they can also, or you can also access the National Domestic Violence Hotline website for additional information to support these teen pregnant moms if they're involved with domestic violence or intimate partner violence. Next is postpartum visit. Let's say you're the home health nurse and your job is to visit new families. Okay, pregnant teens have now had their babies, and you're doing a postpartum visit. What do you look for? What are some positive signs? What are some red flags? That's a question for you guys.
I want to make sure that the baby and the mother are bonding, like she's a teen
Perfect.
mother.
Absolutely. That's perfect. That's a priority. Bonding is a priority. What else is a priority?
Does she have any
Safety.
support or help?
Yep.
The safety of the home.
Safety of the home. That she has information about what's a normal growth and development for the baby. Can she meet the baby's needs when the baby's hungry or needs a diaper change?
Mm-hmm.
Right? The more unprepared she is, the risks go up of abuse and neglect.
Abuse. Yeah.
Right? Does she make eye contact? Does she attend to the baby's needs? What does the home look like? Is there a dad involved? What does that look like? What does the interactions look like? Is it a high stress environment? Is it a supportive environment? Right? Then here's a few examples of primary, secondary, and tertiary related to the teen pregnant client. Okay, what might we do primary? Maybe provide sex education early so that we reduce may reduce the risk of unintended pregnancies. Right? Maybe we educate the parents. Right? Maybe the parents have to participate in sex education at home. Then secondary, how do we screen for high risk adolescents that might be at risk for unintended pregnancies? So we want to try and identify them. Do they have a history of substance abuse? Do they have a history of sexual, physical, or emotional abuse? Are they vulnerable? Do they have those risk factors that might put them more at risk for an unintended pregnancy? Provide resources for pregnancy testing, for STI screening. And then, of course, tertiary, what does that mean? They're pregnant, right?
Mm.
They're pregnant. So now we work with them while they're pregnant, right? What is the immediate, on your assessment, what are the immediate needs? Okay, do they have a OB?
Mm.
Do they have
Prenatal care.
adequate support? Pardon me?
Prenatal care.
Prenatal care. Okay, so teen pregnant is a very high risk population, as is our next LGBT population. Okay, we as nurses have an ethical obligation to provide culturally competent care. Right? There are some nurses that have a degree of discomfort. Right? So this was where the question came about checking our own beliefs, our own biases, our own feelings before we care for this group of clients. Right? We must provide a safe environment for them to be able to talk about their sexual orientation. Right? And Latoya, here is where we also include, if we're working with these clients, we should have an understanding of what the state laws are regarding marriage and family structure, right? Working with this population, we want to ask open-ended, non-judgmental questions, right? The goal is to build trust, right? We can't really make assumptions based on their appearance or sexual behavior. Open-ended questions. So how would we ask them a question that didn't assume heterosexuality rather than saying, do you have a girlfriend or a boyfriend? Maybe, do you have a partner? How does that sound? Pretty non-judgmental? You're not assuming anything? Right?
Mm-hmm.
Are you in a relationship? What do you call your partner? Right? That this opens up that discussion so that they will in turn be able to answer your questions. But we can't assume heterosexuality with that, with this group, with this population, which is why we ask non-judgmental, open-ended questions. And then the other part that I want you to know about is CDC. There are recommendations from CDC about screenings, annual screenings for this particular population. Okay, and this is what it includes. Annual screening for HIV, genital herpes, syphilis, gonorrhea, and chlamydia. So if you're asked a question about how do you, on the next exam, how do you screen, what do you screen for annually with regards to the LGBTQ population, that's what you're screening for. And that's annually. However, in this last part of this says it, if you have to shorten up that interval to 3 to 6 months if they're at higher risk. Those particularly higher at risk, individuals with multiple or anonymous sexual partners, or those who use illicit drugs in conjunction with sex. All right. Does that make sense?
Yeah, I have a question though.
Yep.
So I understand that the CDC recommendations is underneath this particular population's reading. However, isn't that like a universal thing? Like you should get tested every year and then every 3 to 6 months if you are, high risk anyway.
Well, this is talking about this particular population.
Okay.
Yeah. I mean, as far as CDC, I mean, I'm not sure what the CD screening is. Are you saying for like normal healthy?
So, like I'm
Or-
saying, like this paragraph or this little sentence says a requirement, and it's underneath that the particular community. So, what I'm asking you is, don't just like people that's not in that community aren't we supposed to get tested every year for that? And then if you are doing drugs or if you are doing promiscuous things, get checked every 3 to 6 months. I'm just asking, isn't that something normal you're supposed to do anyway? Or is it just to this particular?
This is for this particular population.
Hmm.
As far as, are you like, give me an example of another population.
Me, I got.
Okay, you. Do you, okay, so, or me. What I wouldn't typically get screened for all this on an annual basis. It would be symptom
okay.
management. If I presented with
Okay.
symptoms, then I would be tested.
So, but just in this particular community,
Yes.
it goes back. Okay,
Yes,
understood.
yes.
Because when
Yep.
I was reading that, I was just like, okay, that makes sense then.
Okay. Lots of different kinds of mental illnesses, right? We consider mental illness a special vulnerable population. Once again, with clients with mental illnesses that we're working with, the foundation for a good nurse-client relationship begins with our self-awareness, our own beliefs, right? Our own biases. It's easy to say people with schizophrenia are crazy, right? It's easy to stereotype people with anxiety or whatever you want to think. It's easy to stereotype, especially with mental illness. But part of the foundation for establishing therapeutic relationships with clients with mental illnesses is understanding our own self-awareness. Okay? So anxiety. We talked about anxiety. Anxiety is an expected common emotion. It's common that we have anxiety. However, when it becomes so debilitating that it impairs our functioning, then it's an issue. Right? We're all at risk for anxiety disorders, whether it be physical risk, psychosocial risk, developmental, cultural, spiritual. Okay, we all experience anxiety for very different reasons. But anxiety is common. However, if it impedes your daily functioning, then it's risen to a different level. So there are a couple of mental health diagnoses that I want you to be familiar with. Okay? And I'm not going to go through all these line by line, but I've highlighted them, what I need you to know. This paragraph has to do with general anxiety disorder. Okay, you're worried about general anxiety, so you worry about a lot of things at the same time.
Mm-hmm.
Okay, multiple concerns at a time. Instead of feeling anxious about one particular circumstances, it's multiple circumstances. Okay, phobia, excessive irrational fear of something. Obsessive compulsive disorder, obsessive, recurrent, intrusive thoughts, something you can't stop thinking about. Okay, which creates quite a bit of anxiety, right? It's a compulsive act. You feel compelled to perform it. Washing your hands.
Counting,
What?
like
Yeah,
counting your steps, counting while you're doing stuff.
right. PTSD. You had a question about that. Okay. some kind of previous event that involved maybe a threatened death or serious injury to self or others, which you now experience intense fear, helplessness, or horror. You know, the remembrance of such an event produces feelings of intense anxiety, intense distress. And then what about our client with the suicidal ideations? Right, one of the most important things we have to ensure is safety. Right, if we're working with a patient who has suicidal ideations, our priority is ensuring safety. And take that forward. Do you have a plan? What is your plan? Do you have the means to carry out your plan? Have you attempted suicide previously? If you're the nurse doing that assessment, those are the hard questions you need to ask. Okay? As in all vulnerability, kids are at the highest risk for mental disorders. Okay? Maybe poverty, living in poverty, witnessing violence, being victims themselves, peer pressure, suicidal thoughts. Okay, kids are at high risk for mental illnesses. When I was working in the schools during and after COVID, there was a lot of new mental health issues that came about when the kids started coming back to school. Depression, anxiety, suicidal ideations. Okay, remember these kids were socially isolated, right? A lot of these kids were socially isolated during the COVID pandemic. That produced a lot of mental health issues. Okay. Lithium. I want you to know about lithium, right? Lithium is taken for bipolar. If you are working with a client who has just been diagnosed with bipolar disorder, and they have been prescribed lithium, there's some important teaching points you have to review with the fam or whomever has been prescribed it. Okay. And here, these are your teaching points right here. Whoops. Normal salt intake, report diarrhea, vomiting, tremors, lack of coordination. So I need you to have an understanding of what you're going to teach with regards to lithium. I hope you can't hear that background noise. I have a neighbor that's out on an ATV with a snowplow and he's stuck. So can you hear all that background noise?
No.
All right, good. All right, so that's what I want you to know with regards to mental health disorders. The next special vulnerable population I'd like to talk about is people with alcohol, tobacco, and other drug issues. Okay, we know that substance abuse contributes to a lot. I will guarantee you, every one of us, whether it be ourselves, family members, friends, relatives, co-workers, we have all been affected by substance abuse. Have we not? All of us. Okay. We know that it contributes to lots of risky, a lot of at-risk things can happen. Teen pregnancies, unintended pregnancies, HIV, STDs, domestic violence, child abuse, motor vehicle crashes, fights, crime, homicide, suicide. That's just a few examples, right? What are some contributing factors to substance abuse?
Abuse as a child.
Go ahead.
Self-medicate.
Pardon me?
Abuse as a child, you're an adult or you're a teen, you're trying to self-medicate.
Peer pressure. Illness. Go ahead.
Mental illness.
Go ahead. What did you say? Mental illness. Mental illness.
A
What
loss.
about go ahead.
A loss. Having a loss.
Having a loss. Peer pressure in kids. What about predisposed? Maybe you come from a family history of alcoholics, family history of substance abuse, right? Maybe issues in the
Okay.
workplace, marital issues, divorce, loss of job, right? Lots of things. I mean, thousands of issues can contribute to substance abuse, alcohol abuse, substance abuse. Okay. You can go through the terms and definitions. Just read through it. Nothing you need to memorize, but just read through the difference between what's substance abuse, what's drug dependence, what's drug addiction, alcoholism, polysubstance abuse, right? When you're taking multiple drugs. What I want to focus on are some substance specifics. Nicotine, tobacco. Okay. We quickly can get addicted to nicotine, can we not? Tolerance to nicotine develops faster than any other substance, right? We also know that nicotine contributes to cancer, heart disease, lung disease, emphysema, bronchitis, right? Can also lead to birth issues, premature birth, low birth weight, stillbirth. Okay. What do we want to know about vaping and e-cigarettes? What if a parent says you're trying to work with a family that is a smoking family and there's kids with asthma that live in the house? And the parent says, you say, how's it coming? Have you cut down? You're smoking outside, whatever. What about if they say they're vaping now or using e-cigarettes? Is that good? Is that progress?
They're
No.
still getting chemicals now.
No, that's
And
not
the kid
progress.
can get poisoned if they get into
Yeah.
that e-cigarette stuff.
Toxic. You
That was
getting
my
toxic.
next question. What is the biggest concern about vaping and e-cigarettes around kids?
The toxin.
Poison.
The
poison
toxins, the poisonous oil in those vaping and e-cigarettes. Alcohol, we went through a little bit, right? Alcoholism, alcohol abuse costs billions and billions of dollars in lost productivity, property damage, medical expenses, chronic diseases, family disruptions, right? For those of you that got the question right about what the liver can process, you got it from here. Okay, but have a look at that. Make sure you know that, because that's going to come up in the next exam. Okay, cocaine abuse, right? What is it? Let's assume you're seeing clients in your urgent care, all right, for alcohol. Read about that. Let's say you have a suspected cocaine overdose. What are you gonna observe? Increased sense of energy and alertness, elevated mood, feeling of supremacy. What I want you to know with these different substances is what might you observe? So what are you going to observe with somebody who's using cocaine? What are you going to observe about somebody who's abusing amphetamines or methamphetamines?
They twitching.
Mood swings.
Mm-hmm.
They sniffing. Like.
Yep.
Twisted like appearance.
Mm-hmm.
Mm-hmm. So you're going to get, there's several questions on the next exam about certain substances. So just be aware of what using different substances presents. Some of them have similarities, but others have their own, kind of defining symptoms that they would present with. Okay. What else? Denial. How to assess socioeconomic problems resulting from substance abuse. So here's some examples of what we can do as community nurses. about setting up community-based activities aimed at substance abuse prevention. And here's a whole bunch of ideas. Okay, so be familiar with those as well. Okay, and here's a couple of examples of high-risk groups. Adolescents like to experiment. Older
Ms. Marble.
adults. What?
I'm sorry. What did you say we need to look at again?
Some ideas of what you would do in the community,
Okay.
right? Some set up community-based activities aimed at substance abuse prevention. Here's a list of common examples of what are set up in the communities. Some high-risk groups, adolescents like to experiment. It's part of their development, right? Older adults have higher rates of alcoholism. Sometimes we can mistake alcohol with cognitive changes, right? We have to be mindful of that. Right? Pregnant women with substance abuse issues, risk of fetal alcohol syndrome, risk of low birth weight, birth defects, addicted babies. And then another high-risk group is injection drug users. High risk for overdose, high risk for contaminated needles, which may cause HIV, hepatitis C. Okay? So what you need to know for the next exam is in your notes. Okay, we just went through those. Let's cover week 5. So we're going to shift gears now. Does anybody have any questions on special vulnerable populations? Okay, this week we're going to cover hospice palliative care, death and dying, faith and spirituality, and ethics. Okay, hospice care. All right, with hospice care, we need to focus on keeping the client comfortable, maintaining dignity and self-esteem. That was one of your quiz questions, right? We know that in the process of controlling pain, that's important. However, we don't want to keep the client so sedated that they are not even aware of what's happening, correct? We still want them in hospice to be able to interact with their family members and their caregivers, correct? To try and participate in decisions as much as they can. Okay? Prescribed treatments are to be carried out. Okay? If before going into hospice, the client was able to verbalize what they wanted done to them, and this is all written out in their plan of care, then we need to honor those wishes, right? Let's say a client says, I don't want a feeding tube, right? But the family members who are there cannot bear the pain of their family member not being fed. And the family says, nope, we want a feeding tube. Who has priority? What plans are you carrying out? You're carrying out the client's plans, right? So a hospice nurse would have to work with a family and explaining to them why their priority is carrying out the autonomous instructions from their client. Does that make sense? Hospice is, I don't know if anybody's ever worked in hospice or had a family member that has been in hospice and you have been at the bedside and working with a hospice nurse. It's a very delicate position. Okay? Because not only do we have a client that's in hospice, but we have their family that we're working with. And there's a lot of signals that can get crossed. Right? Hospice nurses they rock. Okay, because they are working with the client, family members, other relatives, and everybody may not be on the same page of how they want the treatments carried out. But if the client has been able to dictate what they want things to look like in hospice care, then that's the priority. All right, so we know in hospice and palliative care, the goal is to alleviate suffering as much as possible, right? We know that in hospice care, there is no cure, right? So if the client is saying something like, well, are there any other treatments that can help me cure this disease? You have to be able, as a hospice nurse, be able to talk openly with the client that there is no cure, right? We don't want them leading them down a false road of hope, right? So accepting that death is normal and and expected, and humanizing that experience. We have to be able to have that discussion with our hospice client, right? In hospice, all aggressive treatments are stopped. There's no more chemo, there's no more dialysis, there's no more radiation, right? The goal becomes you're focused on the quality of life rather than the quantity, right? It's symptom management. And interestingly enough, dehydration, many don't know this, but dehydration in the terminally ill patient has actually been shown to decrease pain and discomfort, right? Rather than having a feeding tube and putting all this formula into the intestine, where they feel full and uncomfortable. So that may be something you have to address with the family. Where's hospice care given? In the home, hospice facilities, long-term care facilities. Hospice can be provided in different settings, right? We know that hospice is the end stage of life, improving quality versus quantity. Okay? Generally, the patient has a prognosis that's no more than 6 months if all treatments were stopped, right? So this is good to know here. This is a couple things to know. What kinds of physical support can we provide a hospice client? Alleviate pain, reduce air hunger, try and improve sleep. Social support, facilitate relationships that may be strained or neglected, or that the client wants to mend. Saying goodbye to loved ones. Remember, this is end of life. Spiritual support, if they choose that. Finding peace with God or whatever their higher power is, maybe through a chaplain or a religious advisor. Lots of kinds of support we can provide these clients. Okay, it's probably a given with regards to the stages of grief, that not only the client but family members are going to be in different stages of grief, right? So we need to have an understanding of what those stages of grief are. And that's in your readings, and it's also here. Denial, anger, bargaining, depression, and acceptance. So the hospice nurse needs to be well versed on these stages of grief, because she may be working with multiple family members that are in various stages. One of the things we don't want to be doing is making decisions for the clients and the family, right? It removes the autonomy from both the client and the family, right? They're already feeling a sense of loss. They have a family member who is in hospice care, right? So we want the client and the family making as many decisions as possible. We don't want to be making decisions for them. Again, with this population, therapeutic communication, open-ended questions, avoid making assumptions. Don't offer platitudes and pleasantries. Oh, don't worry, everybody dies. You're not being punished. God will forgive you. No, it's not what we want to be saying to a hospice patient. right? They should be encouraged to communicate whatever fears they have, whatever hopes they have, whatever their needs are. Do they want a spiritual advisor? If they do, that's your job to find them a spiritual advisor. What's their religion? Who would be best appropriate to meet with them? Again, we have to be aware of our own feelings with regards to death and dying. My husband Tom's mother was in hospice care a couple of years ago, and his caregivers, she was at home, but him and his 4 brothers arranged for round-the-clock home care. They didn't want to put her in a facility. And the group of caregivers they hired they were from the Philippines. Part of their cultural belief in hospice care is letting things happen naturally, where the orders from the hospice doctors were to give her morphine. So this created a big, big controversy, right? Because the brothers wanted to give her morphine to keep her comfortable, but yet her caregivers, that wasn't culturally appropriate in their culture. Does that make sense? So that goes back to checking your own feelings, checking your own beliefs, checking your own values, your practices. Okay? As death becomes imminent, clients spend more time sleeping, appetite fades, oral intake falls, urine output decreases, incontinence may occur. If you've worked with the hospice clients or clients that are dying, you probably have experienced this. Blood pressure, or excuse me, vital signs change. Maybe the pulse goes up, blood pressure goes down. Skin is different, mottled, cool. Maybe respirations become shallow and irregular. Chine-Stokes respirations is common. What are those? Has anybody ever seen a client with those kind of respirations? More and more shallow. Periods of apnea. Right? So it's almost like holding their breath, and then the respirations resume. And then secretions pool in the lungs. Right? As they're breathing, it sounds moist, like you want to go suction them. Right? Hospice nursing is mentally draining, mentally challenging. It's important to understand how you're feeling about things and how you feel about end-of-life issues prior to even going into this kind of nursing. Has anybody ever worked with a hospice nurse? I have. Go ahead, Kelly, what was your experience? Kelly, do you want to share your experience working with a hospice nurse?
Oh, sorry, my computer was acting funny.
That's all right.
But you have to be a very strong person mentally to deal with patients like that. It's really very draining if you allow it to be. So you have to be able to kind of like balance yourself with working with those type of patients and also being able to provide and be home with your family and dealing with your own personal issues as well.
Yeah. Anybody else have any experiences with working in hospice care or having a family member in hospice that wants to share? It's hard. It's hard whether you are the nurse or whether you're the family member. And I've been on both ends. It's hard. Tom's mother's issues with the cultural barriers were extremely challenging. So, okay, faith and spirituality and culture. Okay, this is I love talking about cultural competence. We as nurses, I've been in nursing 40 years this past May. I am still working towards cultural competence. It is an evolving process that you are going to be developing over your whole career. Okay? To be culturally competent, it requires to provide culturally competent care. We have to first understand our own culture and any biases or stereotypes that we hold. Right? We have to approach every individual as unique. Everybody's unique. We can't make any assumptions. We can't place our culture above anybody else's. And we always, to the best of our ability, as we're developing health plans for our clients from different cultures, we have to take into account, to the extent that we can, their traditional health practices in the plan of care. Right? Maybe it's nutritional preferences. Maybe it's who can visit, what gender can visit in the room. Okay, every culture has different values, beliefs, practices that we have to try and incorporate into the plan of care as safely as we can. Okay, so different cultures have different issues regarding time. Okay, and that's where this paragraph is. Some cultures are past oriented, some cultures are present oriented, and some cultures are future oriented. When we talk about past, if there is a culture that is past oriented, they value their ancestors. And then the past, because they're so focused on the past, and so preoccupied with past events, that sometimes it will get in the way of achieving future goals. Right? Where if you're present oriented, right, you're prioritizing the here and the now. Right? Everything is in the present. Sometimes issues arise with present oriented cultures that you fail to plan for the future, or you consider future consequences because you're so focused on the here and the now. And then if you're future oriented, if you are from a future oriented culture, you're much more likely to make sacrifices now in order to achieve your long-term goals in the future. So that's what I want you to be aware of, that each culture has a different focus on past oriented, present oriented, future oriented. And it is what it is, but it does come with some risks. Okay. Cultural competence requires that we approach each client as they are unique. I already said that. And we do get, let's assume you're working with a client that has a culture that you've never worked with before. Never heard of, never worked. What do? How do you become educated so that you're moving towards cultural competence with this group or this client? What do? Ask. Right? Ask them about their culture. What are their values? What are their beliefs? What are their practices? What should you avoid? What's okay? What's not okay? Right? So it's up to you to gather data on their beliefs and expectations. We don't treat every client the same, nor do we expect that we would be treated in the same way. Okay, because every culture is vastly different. Okay, so cultural, most important thing about cultural competence is, or the first thing is that we must view these individuals as unique. We're not the same. So here's an important factual statement. Cultural competence is attained when the nurse makes a conscious attempt to learn about people of diverse cultures, and you want to look at the world through their perspective. Whatever culture it is, you have to be able to look at their culture through their eyes, not make assumptions, be judgmental. And here's some examples of specific cultural practices. Native Americans, they don't like to sustain eye contact in the same way Europeans do. They consider it rude. Jehovah's Witnesses, yes, they'll have surgery, but their culture prevents them from having any blood products administered. Right? Jewish clients have particular preferences, food preferences. They avoid meat from carnivores, pork products, and fish without scales on their fins. Who would have known? Right? So those are a few cultural practices that you may not be aware of. Faith community nurse, quickly. Faith community nurse, whether you belong to a church, a temple, a mosque, doesn't matter. There may be what's called a faith community nurse that works within your congregation. Okay? That nurse, whatever the goals of the congregation are, that nurse performs a lot of different duties. What they're doing is they're adding this spiritual aspect of kind of holistic care in with their clients. Right? It's community oriented, where you're working with the population of the congregation. Okay. Maybe you're doing health education. Maybe you're doing new baby visits. Maybe you're doing support groups. Maybe you're doing grief support groups. Maybe you're working with pregnant clients. Typically, the focus is on health education, health promotion, community resources. Maybe you're doing health fairs. All right. So the faith community nurse working within your congregation to attain the objectives and goals that the congregation has. Okay. The difference with the faith community nurses, they're adding the spiritual aspect of whatever religion you practice into the care. And the last section is ethics and legal issues. One of the first things, if we are making any kind of ethical decision, think of as nursing assessment, your ADPI, think of your A. The first step in ethical decision making is you have to have an issue, right? How are you gonna go through ethical decision making if you don't identify whatever issue is? Make sense? There has to be an issue. Then if you go through your ADPI, you obtain your relevant facts, consider approaches, make a decision, implement the action, and evaluate. So I just took you quickly through the nursing process and how it looks in ethical decision making. But it starts with having an ethical issue. Ethics committees are in all of our organizations we work in. Okay, they deal with ethical dilemmas. Okay, what's moral distress? Moral distress, when an individual is unable to act accordingly with what one believes to be the right course of action. All nurses will go through some kind of moral distress at some point during your careers. All right, you don't agree with the care given. You don't agree with the end of life decisions. You don't agree with adoption versus abortion. You don't agree with, I had a nurse, a student a couple of years ago. She worked in a prison. She worked in the correctional facility. one of the inmates who had health issues. So they had to come to the clinic, was involved in the murder of one of her family members. That's moral distress. Obviously, she couldn't deal with it, and she ended up quitting her job because she was morally not able to care for that client. I mean, that's a pretty extreme example, but that actually happened. Right? So it's important to face the negative feelings that can result from moral distress. You have to discuss it with your teammates, your manager, right? If you cannot safely care for your clients due to a moral issue, you can't abandon the patient, right? What do you have to do? You have got to communicate your moral distress that you're not able to care for the patient so that care can be safely transferred to somebody else who can. Correct? No such thing as abandonment with nurses. Here's a couple of examples. End of life decisions. Your patient load is too high. You're taking care of too many patients. You can't safely take care of everybody. There was a lot of moral distress going on with COVID-19, with visitor restrictions and clients dying alone. Okay? So we all have probably already experienced or will experience many different kinds of moral distress. The point is you have to be able to communicate that. Let's say you get floated. Let's say you get floated to a unit. You work on an adult med surg unit. You get floated to the peds unit. You haven't taken care of peds patients, but you have to go. You can't refuse floating. What would be the safest way when you get there to talk to the nurse manager and say, your moral distress is getting to the peds unit and not having taken care of pediatric patients? Well, maybe a conversation you have with that nurse manager is, listen, I've never taken care of pediatric patients, so I don't feel safe doing that, but here's the things I could do to help you. Right? I could prepare patients for discharge. I could hand out the food trays. I could do this or I could do that. But here's the things I'm not comfortable doing. I haven't done vital signs on pediatric patients. I haven't done asthma treatments on pediatric patients. Does that make sense? There's moral distress that goes on all the time. Oh, here's my floating example here. I want to jump into legal issues. Nursing documentation. Nursing documentation has to be factual. Okay? Descriptive, objective information. What do you see? What do you hear? What do you smell? Okay? So you can't really say, well, they seem to be in a lot of pain. Oh, I think they're feeling worse. No, it has to be factual and objective. All right, seems to or appears to is not acceptable. That's stating your opinion. Okay, the wound was draining. They fell when ambulating, right? Factual. It can't be your opinion. Oh, they seem to be sad today. Patient appears to be depressed. That's not documentation. That's not factual documentation. Okay? There's 4 ethical principles I want you to know, and they are in this paragraph right here. Beneficence, malfeasance, non-malfeasance, Beneficence requires that you do good. You do good within the circumstances. So for example, beneficence would be ensuring you do good, ensuring there's adequate pain control. That's an example of doing good. Okay, another one is non-malfeasance. Those are the two I want you to know. To do no harm. Okay? Do no harm. So an example is, this was in a previous quiz. It wasn't what you guys took. So you're going to cath a client and you contaminate the field. What do? Go get a new
Get a
kit.
new catheter.
Go get a new kit.
New
Right?
kid.
That's an example of non-malfeasance. Do no harm. And another one is autonomy. Really, that's the client's right to be autonomous and participate in their decision making. And then the last thing I want to mention is advocacy. We as nurses, we're always advocates, are we not? Advocacy in nursing is we're using all the information and the resources we have to benefit the client. We're trying to act in the client's best interest. We're always advocating for our clients, maintaining confidentiality, right? Carrying out the wishes of the clients, right? Making sure somebody's received all the relevant information prior to going into surgery or prior to going home or prior to being transferred to another facility.
So, descriptive justice is advocacy.
Correct. Correct. Well, think about what distributive justice means. It's also another ethical theory. Distributive justice means that everybody has the same equal opportunity to resources. Right? So the example used is advocating for insurance coverage of hospice services. Right? You want everybody to have that resource. Distributing justice. Does that make sense? Here is the moral distress. You no longer provide high quality nursing care due to moral distress or ethical dilemmas. You have to arrange for a suitable alternative. You have to have a plan before you stop caring for the client. And here's another example. Working in home health and client is making an unwanted sexual advance towards you when you do the home visits. You might not be comfortable going back to that home, but it has to be arranged for somebody to take over. And that's where you go to your leaders or your managers or whomever. Okay? Care of the patient must be transferred to somebody else. You just can't stop providing care. Okay? Questions? I am going to put this in the chat. Let's see if we can make this work. This is a Kahoot. Let's see if we can make this work. I'm going to put the link in the Kahoot. Okay. And then I'm going to pull it up on my computer. Okay, so there's your link. Let me pull it up on my computer. See if I can get this to work. Oh my God, I forgot the pin. Where's my pin? Let's see, I just put it in your chat.
Miss
Can some,
You want me to tell it to you? It's
Yeah, 1 second.
05
Yeah, what is it? 05
62
62.
9152.
See if I can get in. Okay. Yes, that's me. Oh, shoot. I already started this. Save the link and come back. Oh, boy. What am I doing here? Oh. Let's see. See, I already did this, so I don't know if it's going to let me. Let me try it again.
You want us to log out of the Kahoot and reopen it?
Yeah, you could. I just want to do a couple of questions. Let me share my screen. You guys getting what I'm getting? I'm not great with Kahoots. I really am not, but I'm gonna.
Hold on, give me a second, cause something happened on mine. Let me do this over. I don't know what link. That link not working for me. Hold on.
Miss Marvel, it's like set up different. It's not like you wanted us to play as a class or you wanted us to do it individually.
I want to try and play as a class, but hang on.
If you
I'm-
just go to Kahoot and
What?
just put in if we try to go to just to Kahoot, I didn't use your link. Your link had me doing it by myself. So I think if you try to go to Kahoot, just type in Kahoot and then put in that game pin, we should be able to do it all together. So
Okay.
don't use that link. Just kind of type in Kahoot.
Okay.
Let me see.
Okay. You mean just sign into my own Kahoot?
Oh, yeah, never mind. It's not working.
Hang on.
It just sent me back to.
Yeah, I don't know because you can click it. I don't know. It's like we control it ourselves too.
All right, you know what I'm going to do? I have a different idea.
Mm-hmm.
I'm going to send you in an announcement the Kahoot, so you guys can do it on your own. How's that?
Yep,
Okay,
I'll
that's
do that.
fine.
I'll
it's
do that.
fine.
When I send you the recording, I'll send you the Kahoot. The last thing I want to go over with you guys is the HESI prep. Can everybody see my screen?
Yes.
Okay, there's a lot of things you can fill out in this now. Okay. Remember, this is a document that you are working on. This is eventually going to be your HESI study guide. So you should be working on this through the term. Okay. We're going to cover the concepts, but not everything. I'm not going to cover everything that's in this document. You're going to have to do some research on your own. For example, we haven't done anything with disaster yet or bioterrorism. You can't fill that in. We haven't done epidemiology yet. Okay, but we have done some health promotion and teaching. Okay, I want you to remember that each of these boxes on this document represent a question on HESI. I don't know what the question is, but I know what the topic is. And all these specific topics are within a certain concept we're working with. Like conjunctivitis, that was in your common childhood ailments, lead poisoning. Lipid screening, you're going to have to go and look and get it. We're not going to cover that. I mean, I can't vision screening preschool. Whatever we haven't covered specifically in class, you're going to have to go back and do your own research. So between your PEDS book, your fundamentals book, your med-surg book, this information is all in there. Okay? We just scoliosis screening, seatbelt safety. All right, so all these are in specific concepts that we covered, but you're going to have to do some of your own research as well. Like with where is my migrant? Vulnerable populations. Okay, you can fill out those. So there's parts of this that you can already complete. This HESI for community is very med-surg focused. Look at all the med-surg questions: cirrhosis, post-arthroplasty, cabbage. Okay, so whatever you put into this assignment, you're going to get out of. All right, so if you wait till week 8, it's due week 9 to start filling this out, it's going to be a long, tedious, time-consuming assignment. But if you're filling it out as we go, it's by the time you get to week 9, you're just going to be able to just have to submit it. But remember, this is what you're going to be studying for. Okay, in the term over the weeks, we cover concepts. I'm not going to be covering every specific item on that HESI prep sheet within the concept. My job is to give you guys a big picture of what these concepts mean. And the HESI is going to be asking you specific questions about items within that concept. And so at least you have the topics that are going to be asked about. I don't know what the questions are, but like, for example, they're going to ask something about scoliosis. They're going to ask something about whatever's in that box. So it's up to you to if you can't answer those boxes from class lecture, you're going to have to go into your books to get that information. I can't cover everything. Does that make sense?
Yes.
When it says use the nursing process, what that's, I don't need you to write out A, D, P, I, E for each box. No. What it means is, let's take scoliosis screening. I think that was one of the boxes. Think of the nursing process. What are you going to do? In your assessment of that kid, how are you going to position them to do your scoliosis assessment? Does that make sense?
Mm-hmm.
So the HESI is very clinically and med-surg focused. So you need to be thinking about what are you going to do when a client presents to you with potential spine issues and you're going to do a scoliosis screening? How does that look? Eczema. A client presents to you with whatever, rash, itching, whatever. What kind of assessment are you going to do for that kind of client? You need to be thinking ahead to HESI as having the knowledge from what you've learned in class and using that for clinical judgment as you're taking care of clients with all these different kinds of things in the community. Does that make sense? Does that help?
Yep.
Okay. Well, I want to be mindful of time. I know we're supposed to get done 10 minutes early, so I'm already 5 minutes over that. So I apologize for that. We covered a lot today. Has this been helpful? Did you learn a lot today?
Yep.
This continues to just build your knowledge about what we as community nurses are responsible for in the community. There are a lot of different clients that need to be taken care of in a lot of different ways. Right? All right, I've got some meetings scheduled after this class. I need to log off so I can get my recording going. So for those of you meeting with me right after class, why don't you come back on in about 15 minutes? Okay, I've got to get this recording going.
All right.
It was good to see everybody. I hope everybody has a good week. Okay, reach out if you need anything, okay?
Yes,
All right.
ma'am.
Have a good week.
Bye.
Bye.
Bye.